Hello, everyone, and welcome to the master's essay presentations. Hopefully you are in the right Zoom room. My name is Celia Karp, and I'm an assistant professor in the Department of Population, Family, and Reproductive Health. And we're really excited today to have some presentations from our amazing master's students in the department. And this is really the culmination of their work in the program and highlighting some of the work they've been doing related to their specific areas of interest, and often in conjunction with their field placements. So during today's session, we have 4 presenters, Anusha, Isaac, Jessica, and Merone. They'll be going in that order and each presenting for about 10 minutes. We will save 5 minutes for Q&A following each presentation. So please feel free to pop questions in the chat if you have any questions that come up during the sessions, and we will address them during the Q&A. Any questions that can't get addressed in those 5 minutes will just carry over and presenters can chime in via the chat. But I know folks really appreciate questions for the work that they've done. So, okay, we're going to switch things up and move to Isaac. Isaac, are you still here? Yes, there you are. All right, Isaac, and we will go back to Anusha once she rejoins. So our second presenter, now first presenter, is Isaac Amoah-Ebonyi. Isaac joined us after obtaining a Bachelor of Science degree from the University of Ghana Medical School with a major in medical sciences, as well as a Bachelor of Medicine and surgery. Here at Johns Hopkins, Isaac's areas of interest are women's sexual and reproductive health. And today we're excited to hear his presentation, Beyond Utilization, the Long-Term Impact of Assisted Reproductive Technology, ART, Insurance Mandates on Fertility, Equity, and Public Health Outcomes in the United States. Isaac, please feel free. Okay, great. We are on your importance and background slide. Go ahead.
Okay, thank you very much. Sorry for the hitches. My master's essay is a research proposal titled Beyond Utilization, the Long-Term Impact of Assisted Reproductive Technology, Insurance Mandates on Fertility, Equity, and Public Health Outcomes. While most of the existing literature focuses on how many people walk through the doors of a clinic when insurance is provided, this study aims to look further downstream. I will be asking fundamental questions like, do insurance health mandates, actually the policies, do they actually change the landscape of who is having children, when are they having them, and the overall fertility health of the American population? To understand this essay, I would like to look at the current burden of infertility. Infertility currently affects approximately about 12 to 15% of couples in the United States, whilst ART and in particular IVF now contribute to about 2% of overall birth in the United States. Its access is profoundly unequal. Infertility actually is not just only medical condition, but it's a source of a significant psychological distress and social stigma that affects many families. The primary barrier to care for infertility is cost. In fact, a single IVF cycle typically runs between $12,000 to $24,000 in the United States. And because multiple cycles are often required for success, the financial strain often leads to incredibly high discontinuation rate. Essentially, many families stop treating for infertility or using IVF, not because they had reached their goals, but because they had run out of money. And this is the world barrier that I intend investigating through this research. In response to the cost, about 21 states and Washington, D.C. had introduced an insurance mandate as of 2024. However, these policies vary widely across the country in both coverage and eligibility. What does the evidence tell us so far? We know that these mandates actually work at the clinic level. They increase ART utilization, reduce out-of-pocket costs, and significantly reduce the rate at which patients drop out of treatment due to financial exhaustion. But here is where we hit the wall in our current understanding of mandate. We know that people are using the clinics more, but we don't know how the long-term it impacts on families. The research gap is that the existing studies focus almost exclusively on utilization, meaning clinical volumes. We don't yet know if these policies translate into measurable changes in population-level fertility patterns. It is one thing to see more people using the clinic or visit the clinic. It is also another thing to see a shift in actual number of births or change in maternal age at first birth across the entire state. This leads me to my core question, my core research question, that what is the long-term impact of state-level ART insurance mandate on completed fertility in the United States? And I hypothesize that mandates, and especially comprehensive ones, will lead to higher age-specific fertility rates among older women and a higher likelihood of families achieving their intended family size. This framework illustrates the pathways with which I will be investigating to get answers to my research question. I will start with the policy, the mandate. This creates a financial protection which leads to the intermediate steps of utilization. However, my focus is on the fertility behaviors that follows: the ability to safely delay childbearing and the progression to have either a second or a third child. Crucially, I will also be looking at moderators like race, ethnicity, education, and others. The goal is to see if removing the financial barrier allows couples to realize their true fertility intentions. My focus will first estimate the causal effect of ART insurance mandate on age-specific and total fertility rate. And second, evaluate whether ART mandate reduce racial and educational fertility disparities. Third, assess the impact of mandate on maternal age distribution and multiple birth rate. And finally, construct and evaluate a policy generosity index to determine the dose-response relationship. To answer this, I will utilize a quasi-experimental differences approach. Because states adopted these mandates at different times, we can compare the changes within mandates over time and relate it to those that did not implement them at all. This will allow me to isolate the effect of policy itself from the general national fertility trend. I'll be using the National Center for Health Statistics statistical natality files from 2003 to 2023. This gives me a massive data representing over 70 million births. The data is near complete of the registry of all births in the United States, which gives us the statistical power to see real population shift and conduct detailed subgroup analysis. My primary exposure will be the state-level mandate, which I'll not treat it as just yes or no variable, but use a policy generosity index to account for the strength of the coverage, especially looking at whether the policy actually included IVF, the number of cycles, or just limited to just a few. My primary outcome will be the age-specific fertility rate and the total fertility rate. And I will also look out for secondary outcomes like parity progression, whether people are able to get the second or the third child, and also look out for multiple birth rate. The latter being a very key public health indicator, as mandates often encourage single embryo transfers, which is safer for both mother and the baby. The analytical strategy will use this equation that you see on this slide to control for state and year fixed effect. And I will also adjust for state-level covariance like unemployment rate and the presence of other reproductive health policies to ensure that results that we get aren't being driven by external economic or political factors. Or identify the various targets by comparing the changes within the state over time to changes in the non-mandate state. This will help me isolate the causal effect of the policy. And finally, to ensure the validity of the claims that we'll make, I will conduct an event study. This will allow me to test for parallel trends, ensuring that mandate and non-mandate states were on similar trajectories before the policies were enacted. It will also help us to see how long it takes for policies to actually impact birth rate, what is termed as the lag effect. The strength of this study lies within the 20-year longitudinal panel that I intend to use, and also the population level data rather than just clinic samples. And also the design will provide a very strong causal inferences to be made, as well as capturing timings, a dose response, and equity-focused evaluation. But however, the study may be limited by the fact that I cannot directly identify individual ART births in this massive data set. Consequently, my exposure will be measured at the state level, where results may be influenced by cross-state migration or other concurrent policies that exist within the state. In conclusion, the strength of this study lies in the fact that it's a 20-year longitudinal scope, and by moving the conversation from how many cycles of IVF have you used to how many families you have, we can better understand the role of policy in supporting reproductive autonomy. If these mandates reduce disparities, it will provide a very powerful argument for exploring ART mandate or for expanding ART mandate coverage nationwide. Thank you. And on that note, I want to express my sincere gratitude to Dr. Celia Karp, Dr. Ian Silas, and then Dr. Sally Safi for their immense guidance, mentorship, and contribution towards this research. Thank you very much. These are my references.
Thank you so much, Isaac. That was a wonderful and very comprehensive presentation of your research proposal. Thank you. And great to start us off with the intersection of some reproductive health outcomes and potential policies. So I will get started to see if anybody in the audience has questions for Isaac related to his presentation or broader work. All right, well, while folks think a little bit, and I believe we have about 3 minutes for questions, I'll ask you one question, Isaac. So I know you were interested in kind of the long-term impact of ART policies and insurance mandates on those outcomes that you highlighted, like age-specific completed fertility, and you mentioned looking at kind of how people were able to achieve their fertility intentions. What are your thoughts related to kind of how you might see variations, if you would see any variations in those relationships across states in the United States? I don't know if that was something that you were interested in looking at, or if you had thought about kind of state-specific variation that you might see with these mandates and how they're impacting population dynamics and reproductive health.
Yeah, thank you very much, Dr. Karp, for that question. Yes, what in my readings, what I noticed was that some states are heavily geographically actually concentrated with the IVF procedures. They will have quite a lot of fertility clinics, and particularly in California, Michigan, and a couple of places. Mm-hmm. So access is very is great. Whereas when you get to certain places where fertility clinics and other things are very low, in fact, I think when it comes to this reproductive health in trying to solve infertility with IVF, it's probably more or less like non-existent. But what I realized that it is in all that comes together to actually gives the fertility rate, the national fertility rate of below 2.1, the replacement level. So it got me this interested that if I could get in and really segregate this to various states, then we can know which state is actually doing well, and if we can relate it to the presence of ART assessment access there, then we can actually make a case for those states that have those limited
more limited access to
treatment there.
Yeah, great. Very important thought about kind of what the health system landscape looks like for
Exactly.
accessing, even if the insurance mandates are there, are they able to access care and what that might mean? That's an important point. Do we have any other questions for Isaac? I'll give folks just a minute. All right. Well, if anybody has additional questions, please put those in the chat, and please join me in sharing an applause for Isaac. Congratulations on your master's essay and great presentation. Great. We will move on to our next presenter, Jessica Gibson. So Jessica, please feel free to go ahead and share your slides, and you can come off mute. Perfect. So Jessica's area of interest is women's sexual and reproductive health, and she joins us after receiving her Bachelor of Arts degree from Stony Brook University with dual majors in biology and sociology. And here at Hopkins, Jessica's master's essay is focused on intimate partner violence. And her essay presentation is entitled Inflammatory and Stress Biomarkers in Intimate Partner Violence and Cervical Cancer, a Scoping Review. Go ahead, Jessica, please take it away.
Good afternoon, everyone. So I will go ahead and get started because I have a lot to cover. So IPV, or intimate partner violence, typically involves physical or sexual violence, stalking behavior, and or psychological aggression by an intimate partner. And I don't have it on the slide, but I think it's important to note that everyone's experience is different. And so some individuals may only experience a physical or sexual violence, and others may only experience the psychological aspects of IPV. Then, according to 2012 to 2016 prevalence data in the US, 7.2 per 100,000 women per year are diagnosed with cervical cancer, and globally, an estimated 662,301 new cervical cancer cases and 348,874 deaths occurred in 2022. So stress, which is known to suppress the immune system, may be an explanation for the association between IPV and cervical cancer. So different biomarkers such as C-reactive protein, interleukin-6, and tumor necrosis factor alpha, or TNF-alpha, are all chronic systemic inflammatory markers that are driven by chronic stress and trauma, and they are strongly associated with IPV. And C-reactive protein also has been shown to be at increased levels in patients with cervical cancer. So why is this topic important? Well, women are disproportionately affected by women are disproportionately affected by IPV, with 1 out of 3 women in the US reporting experiences of IPV. IPV has been associated with numerous adverse health outcomes, including gynecological cancers. Cervical cancer is the 4th most common cancer among women globally, and there are several biomarkers that are understood to detect cervical cancer and predict prognosis. However, many of these biomarkers are under-tested in IPV survivors. So the objectives of my review were to identify inflammatory and stress biomarkers that are associated with and tested in both IPV and cervical cancer, explain the clinical significance of these biomarkers, consider the clinical implications of this knowledge in terms of screening and prevention. And so I only used one database, and that was PubMed. And these are my search terms to the right. They're very specific, as you can see. I have 4 search terms here. And then I conducted my screening, my title and abstract screening, and my full text review all through Competence. And then I had a variety of different inclusion and exclusion criteria. So I only included studies that were published between 2006 and 2026. They had to be empirical or quantitative and in English. And I only include studies that looked at human females. So no animals, of course, and then no children or adolescents, and no males. And then my exclusion criteria was I exclude studies that didn't have measurement of inflammatory or stress biomarkers, no exposure of either IPV or cervical cancer, missing title and abstract or full text, in a non-English language, and of course studies that included children, adolescents, or males, and then any like qualitative studies and things like protocols and clinical guidelines. The study location and method of biomarker testing was unrestricted due to limited literature on the topic. And so my database searches resulted in 146 articles, of which 7 studies met the inclusion criteria. 2 of the studies focused on cervical cancer, while the 5 remaining studies focused on IPV. And of the 7 studies, 2 were retrospective cohort studies and 5 were cross-sectional. And I did make a note here that because of these very specific study designs, we can't really establish temporality or causal relationships within any of the studies. In comparison to maybe some other studies such as randomized controlled trials or longitudinal studies. And then in terms of methods of testing, so 3 studies used blood samples, 1 study used hair samples and looked at cortisol, 2 studies used saliva samples, and then 1 study used plasma, saliva, and oral mucosal transudate or OMT samples. And then a variety of different biomarkers were tested. So 1 study looked at eosinophils, ELR, NLR, neutrophils, lymphocytes, and systemic immune inflammatory index. 2 of the studies looked at interleukin-6 or IL-6 and C-reactive protein. 3 of the studies looked at cortisol, which is a stress biomarker, and then 1 of the studies looked at IL-6, SIL6R, and CRP. And so the main thing I was trying to get at with this review was to look at overlapping biomarkers between IPV and cervical cancer. So IL-6 and C-reactive protein, which are both inflammatory biomarkers, were tested in 1 of the studies that focused on cervical cancer, and then 2 of the studies that focused on IPV. I think it's important to note that none of the studies included in the review examined inflammatory or stress biomarkers simultaneously in both IPV and cervical cancer, nor did they examine the intersection of biomarkers between the 2 exposures, which was my original idea, but I had to pivot a little bit once I actually looked at the literature and realized that there was actually no literature that looked at those things. And then 1 of the studies on cervical cancer saw that HPV-18 infections were associated with decreased immune function and higher inflammatory levels. And then 2 of the studies saw that IPV was associated with increased CRP levels. And so the implications of these findings are that these findings highlight the importance of testing inflammatory biomarkers in women with IPV exposure to determine if they're at an increased risk of decreased immune function and thus at increased risk of infections associated with cervical cancer such as HPV. And having an understanding of how inflammatory and stress biomarkers overlap between IPV and cervical cancer will allow clinicians to better understand which women who experience IPV may be at greatest risk for cervical cancer. And then in terms of future considerations, studies should examine inflammatory and stress biomarkers in women who have both exposures simultaneously. And then longitudinal studies would be interesting to be conducted to allow for observation of changes in biomarker levels over time. So to see the effects of acute inflammation versus chronic inflammation exposures. And then more demographic data should be reported within the studies to allow for comparisons across race, ethnicity, age, and socioeconomic status. I do have a results table that I wasn't able to fit into the slides that looked at different population characteristics within the studies. But some of the studies didn't really go into great detail about like the specific demographic data. And actually one of the studies didn't really look into demographic data at all. So I think it's important to look into that. And then these are my acknowledgements. I have a really long list here. I want to thank Shannon Wood, who's my master's essay reader, for Karishi, who's my advisor, Dr. Paula Denoria, who's my mentor, my dad, Rascal, my cat. I really would like to shout out Claire Twas, who's one of the JHU librarians who helped me with my search strategy. Of course, Pop Fam faculty, administrators, my cohort, and of course, family and friends. I have all my references here at the end, several pages of those. And thank you for listening.
Wonderful job, Jessica. And thank you everyone for joining me and offering Jessica a round of applause for her presentation. We'll start to see if any students have questions or anyone has questions they'd like to ask or add to the chat, and I'm happy to read those aloud. All right, quiet bunch today. Well, folks, oh, go ahead, Emmy. I'm sorry, I saw you on mute, so I saw you on mute.
This is really a procedural question, Jessica, but I was very struck when you said, well, you sort of had to pivot your your focus because of what you found. And I was wondering if you had any suggestions for other people as they do projects like this and find, what do you do? And what does that tell you about what you're looking at? I thought that process comment might be helpful to people because this happens, as you know.
Yeah, so my original idea, like I said, was to look at the two exposures simultaneously, so IPV and cervical cancer, and then look at the inflammatory and stress biomarkers within those things. But actually, when you look on PubMed and when you type in intimate partner violence and cervical cancer, only like 59 articles have all pop up, which is not like reasonable, right? I was like, oh no. So, but then when you look up cervical cancer and biomarkers or intimate partner violence and biomarkers, way too much literature pops up. So then I realized that I had to like kind of figure out what kind of biomarkers I wanted to look at. So to looking like a little bit of literature, I decided to focus on inflammatory and stress biomarkers. And then that's really when I met with Claire, one of the JHU librarians, to kind of like really refine my search terms because yeah, there's just too much literature like broadly with biomarkers out there, which is great. Um, but yeah, I definitely had a pivot, which it turned out okay.
Yeah, and the thing is that in some ways it was a refinement, right?
Yeah.
Because it was, you're interested in these things, but then you sort of focused on these specific pieces. And Mary Alice made the point that, yes, it also reveals a gap. So that's just the point I wanted to highlight. So kudos to you for such good work. And thank you for sharing that.
Great, thanks, Emmy. That was a good tidbit that you picked up on during the presentation about how these processes sometimes reveal other gaps that, like Mary Alice pointed out, that's an important gap and opportunity for research in and of itself. And I'm just going to ask Blair's question. Blair's asking if you have any plans to publish this work, Jessica.
Yeah, so I might revise a little bit or edit a little bit my paper. I did look into different ways of publishing my work. I know some of the ways in which you publish it, you have to be very specific about how you edit your paper, your manuscript before you submit it. So I am looking into doing that. That would be like maybe a summer thing to do after I graduate and get settled.
Yeah, great. Well, thank you so much for sharing your work and for highlighting kind of the intersections of these two, reproductive health outcomes that we tend to look at separately. So thank you so much. And everybody join me in giving Jessica another round of applause. Great work, Jessica. All right, we will move on to our next presenter. Merone, you are up, so please feel free to share your slides. Our next presenter is Merone Eshetu, and Merone joins us again after we have several students in this group who obtained their undergrads from Johns Hopkins. So Merone joins us in the School of Public Health after obtaining her Bachelor of Arts degree in Public Health Studies from Johns Hopkins. And here in the PopFam department, her area of interest is in maternal, fetal, and perinatal health. And today we'll hear about her work on her master's essay, The Role of Medicaid in Home Modifications for Children with Disabilities, a landscape analysis from 5 states. So go ahead and take it away, Merone.
All right. Thank you, Celia, for that introduction, and good afternoon, everyone. So I'm going to talk to you today about my master's essay topic, and this research was part of a larger study with at the School of Medicine with the study team listed here. So I'll start first with how we conceptualize disability. We use the UN Convention on the Rights of Persons with Disabilities definition of those who have long-term physical, mental, intellectual, or sensory impairments, which in interaction with various barriers may hinder their full and effective participation in society on an equal basis with others. And home modifications can address some of these barriers that exist within the home. Home modifications are changes to the home environment that promote accessibility, safety for both the child and caregiver, and functional independence in the home. They also increase quality of life for the child and family and lessen the demands and physical toll of caregiving. Some examples include a roll-in shower and removable shower heads, stair lifts, or keyless entry systems to get into the home while pushing a wheelchair. It also includes, like, for a child with autism, improving safety with special door locks and alarms that help prevent them from running away. And despite the known value of home modifications, a lot of families still have trouble accessing them due to the significant cost, as they can cost upwards of tens of thousands of dollars. So one of the ways that families can get funding for home modifications are through Medicaid home and community-based services, or HCBS programs. HCBS programs fund home modifications and other services through a Medicaid state plan as an entitlement benefit or waivers designed for specific populations with their own eligibility criteria. And the existing research around home modifications through Medicaid HCBS has focused primarily on, or focused on, adults, so this analysis aims to address that gap. So the larger study included 61 total interviews from 10 states with key informants who could speak about the home modification access in general. And this analysis used a sample of 15 interviews from 5 states related to Medicaid specifically. So key informants who operated state plans or waivers that offered home modifications. And we also included the family advocates who could speak to the beneficiary experience. And over half of the key informants had lived experience with disability, either as a person with disability or a caregiver. And we conducted semi-structured interviews with 3 different interview guides based on each key informant's area of expertise. And the transcripts were analyzed using a rapid qualitative data analysis approach, so summarizing each interview within a set of predefined domains that were informed by the EPIS implementation framework, which we used to develop the interview guides. So although there are significant differences in the structure and scope of programs between the states, key informants highlighted Medicaid as a primary pathway to home modifications for children with disabilities in every state. And there were 4 major themes, which were fragmented service delivery, administrative complexity, restrictive policies, and gaps in expertise. So first is fragmented service delivery. States operate multiple programs that offered home modifications within Medicaid state plans or waivers, sometimes housed within different agencies that have their own policies and staff who have limited knowledge about the other programs available. Families identified their options through referrals or informal knowledge like word of mouth, or family advocates that acted as care coordinators and referred families to the right Medicaid programs. One family advocate said that other states have a single point of entry where you call one phone number and they send you wherever you need to go. We don't have something like that, so people end up calling all sorts of places. Second is administrative complexity. The application process for home modifications through Medicaid typically included securing documentation, managing denials and appeals, having to get multiple bids from contractors or vendors for installing the modifications. And key informants also described how denials were often vague or difficult for families to interpret, which made the appeals even harder. So one Medicaid service coordinator said that the application is lengthy. There's a lot of supporting documentation. We go back and forth, sometimes for years, to get somebody approved in the first place. Third is restrictive policies, such as diagnosis or level of care requirements, which leave out some kids who still need home modifications, but don't meet the narrow eligibility criteria. There's also low funding amounts, long wait list due to limited capacity, and restrictions on the types of modifications that programs can cover. And the policies can also be interpreted very narrowly. So a Medicaid waiver administrator said that if a person is completely dependent on a caregiver for help, a home modification might not be approved because the home modification won't increase their independence. It's just for caregiver convenience. And across the interviews, we've seen that vague policies like increased independence, or requirements for medical necessity can be interpreted very differently based on the agency or the person who's actually approving the modification. And fourth is gaps in professional expertise. In most programs, no one with specialized knowledge, like an occupational or physical therapist, is involved in determining what modifications are needed or ensuring that they're built correctly. So here, a Medicaid waiver administrator said, we need a person who specializes in modifications, a rehab person, an engineer, or someone who specializes in understanding modifications and the specifications we get from vendors. We don't have that level of reviewers when we get those modification requests in. So given these four themes, while we know that Medicaid through HCBS state plans and waivers cover home modifications, there are significant barriers for families to actually benefit from them. These findings highlighted two levels of barriers that families face to receive home modifications through HCBS. First, in order to actually get into an HCBS program, families have to navigate fragmented systems to even learn what they might qualify for. For programs with family financial eligibility criteria, income may not reflect a family's financial need, especially since families with children with disabilities report increased financial hardship. Disability eligibility criteria, which are often based on diagnosis or level of care, is also limiting, as there are children whose home environment doesn't meet their needs and they could still benefit from home modifications, but they don't fit some of the program's strict diagnostic criteria. But even once families are enrolled, there's a second layer of barriers involved in actually receiving the home modifications through those programs. That includes low funding caps, lack of professional expertise, contractor shortages, denials, administrative burden, and long wait lists. And a lot of these challenges may disproportionately impact families who already have a limited ability to navigate such complex systems, such as families with lower health literacy or low English proficiency. So a major strength of this study is the diversity of key informants we included, who represented a variety of organizations and allowed this study to capture a range of perspectives, and the use of the implementation framework in the study design, which helped identify implementation barriers across multiple levels, especially for such a complex system. And the limitations of this analysis is that the subsample was limited to only 5 states and might not reflect the full range of Medicaid-funded home modifications nationally. There's also variation in the depth of information we received in the interviews. And since this analysis only used key informant data, the findings might not align with the actual written policy or potentially some other perspectives within the state. And the study also didn't include family or contractor perspectives. So I'm going to end with some future research and policy implications. Key informants shared a variety of opportunities to improve HCBS programs, many of which could be evaluated in future research for their influence in access to home modifications for children with disabilities to help identify best practices and better inform policy. These include single point of entry models, consolidating multiple HCBS waivers into one program, eliminating parental income requirements or implementing sliding scale models, adopting inclusive functional eligibility criteria, increasing funding, integrating professional expertise into the process, and reducing administrative burden for both families and for contractors. So thank you. And I would also like to thank my reader, Dr. Becky Seltzer, who's on this call today, and for all of her support through my time as a research coordinator on the project. Also the HomeMod study team and all of the key informants who donated their time and expertise to the study, and then my friends and family for all their emotional support throughout this process. And also I will be sharing a link to a film that Dr. Seltzer actually produced from a previous project in the chat for you guys to get a perspective on what the home environment looks like for children with disabilities.
Great. Thank you so much, Merone. Thank you. This was a really wonderful presentation and a deep dive into a really important topic. So Thank you so much for sharing your work on this project and with the broader study team. I will open it up for questions to see if anybody has any specific questions for Merone related to this work. Yeah, go ahead, Blair.
Hi, can you hear me okay?
Yes.
Thank you so much, Merone. This was just an awesome presentation. Love to see the qualitative analysis that you did. I love seeing qualitative data being used for these really applied sort of MCH topics to help us make better decisions. I'm wondering if any of the 5 states that you included in your analysis, if you heard from your key informants that there was a kind of partnership between the Medicaid program, Medicaid managed care, and the state Title V program, specifically the Children and Youth with Special Healthcare Needs kind of branch of that program. Did that partnership come up as a way to kind of, I know those partnerships are sort of newly forming in states as the states are changing their Medicaid sort of models for this particular population. And I just wonder if that came up in your interviews and if that, I don't know, might inform some of these barriers that we were talking about, especially with this care coordination issue, some of the administrative burden, and just documenting needs in a specific way for this population that Title V does pretty well.
Yeah, actually, there was in one state a program that was funded through Title V. It wasn't a managed care organization, but it was similar. It was like a it was an organization that was contracted to provide the Medicaid services to families. And that was funded through Title V, which housed made the policy decisions and funded them directly. So it kind of sounds like you're getting at that. So there was one, and it was really interesting to hear about.
Great, thank you. Thanks, Blair. I was also interested. We're gonna move on because of time with our 4th presenter, but I was also interested, Merone, in your ideas about kind of looking into the alignment of the state-specific policies or Medicaid policies with these perspectives that you're seeing, because you mentioned that as kind of one of your limitations. So I don't know if you've thought about that as kind of like a potential future direction for this work, but could definitely use that to try to identify some gaps in alignment between what the policies say and what's actually being done in practice potentially.
Yeah, that is something that I thought about and that we talked about as a team. I think it's really important to also like highlight what the discrepancies are between what our key informants are saying and what actually exists in the policy to get a better idea of like where those implementation gaps are happening. But I think part of like what I really like about this study is that it is purely just key informants' perspective. And I think that is how it is being implemented is by these administrators. So I think it still gives such a rich understanding of what is actually happening in the programs compared to if we were doing more of a policy-based analysis.
Yeah, great point. All right, well, thank you so much for your presentation, Merone. And if others have questions, please add them to the chat, where we are also celebrating Merone's recent recognition for her paper. So please check that out over in the chat. And thank you, Mary Alice, for highlighting that. All right, we are circling back for those of you who were with us at the beginning of this session. We have Anusha Sarkar, who is joining us from a different location with stronger Wi-Fi. Anusha joins us after receiving her Bachelor of Arts degrees in Public Health Studies and Cognitive Sciences from Johns Hopkins University. And here at the Bloomberg School, her area of interest is in child and adolescent health. Anusha, please feel free to share your screen just so we can get all set up. And Anusha's master's essay title is Exploring the Impact of Psychosocial Factors on Parenting Self-Efficacy Among Latina Mothers at Risk for Postpartum Depression and Anxiety. Anusha, please take it away.
Hi everyone, I'm just going to get right into it for time. So, postpartum depression and anxiety are significant public health concerns. About 13% of individuals who recently gave birth report postpartum depression symptoms. And while some research suggests lower prevalence in the Latina population, this might actually reflect underreporting rather than truly lower rates. In fact, Latina women face unique risk factors for perinatal mental health challenges, including immigration-related adversity, acculturative stress, language barriers, and limited access to culturally responsive care. We also know that postpartum depression doesn't just affect the mother, it has consequences for the child as well. And research consistently shows that postpartum depression is associated with less responsive parenting, decreased affection, and reduced involvement with the infant. And for children, this translates to increased risk of developmental delays and behavioral problems. And while we know that depression and anxiety affect parenting, I wanted to explore what specific psychosocial factors, such as behavioral activation, mood management skills, perceived social support, decentering and rumination, or perceived stress might help explain this relationship. And it's also important to study this specifically in Latina mothers who are understudied in perinatal mental health research while experiencing a distinct environment with population-specific stressors and supports. So this led me to two main questions. First, are psychosocial factors associated with parenting self-efficacy beyond the effects of depression and anxiety symptoms? And second, do psychosocial factors moderate the relationship between postpartum depression or anxiety and parenting self-efficacy? Based on existing literature, I expected depression, anxiety, and perceived stress to be negatively associated with parenting self-efficacy, while behavioral activation, mood management, perceived social support, and decentering would be positively associated. And this study was more exploratory, so I didn't have specific hypotheses beforehand regarding mediation or moderation. So to answer those questions, I conducted a secondary analysis of baseline data from the Mothers and Babies virtual group randomized control trial. And for some context, Mothers and Babies is a cognitive behavioral therapy-based intervention designed to prevent postpartum depression. The virtual adaptation was delivered across 10 sessions to Spanish-speaking Latina mothers who were recruited from Maryland Judy Centers, which are early childhood programs serving low-income families across urban, suburban, and rural counties in Maryland. And to be eligible, participants had to be Latina, age 16 or older, Spanish-speaking, at risk for postpartum depression based on screening tools or staff referral. And mothers with likely current major depression were excluded because this was a prevention-focused sample. So here are all the measures that were used. They were all administered in Spanish, and my primary outcome, parenting self-efficacy, was measured with the PCODIS, or Parental Cognition and Conduct Toward Infant Scale, that captures a parent's self-perceived ability to perform caregiving tasks. And the measures used for depression and anxiety were the CEST and GAD-7, which have also been validated in Spanish-speaking populations. The final analytic sample included 88 Latina mothers, and on average, participants were 30, had lived in the US for 7 years, and had between 2 and 3 children. Mean depression scores were in the at-risk range but below the clinical cutoff, and parenting self-efficacy scores were high with the ceiling effect that I'll address in the limitations. And to explore my research questions, I conducted a series of linear regression models with bootstrap confidence intervals to address non-normality in the parenting outcome. And I'll start off with the bivariate associations with parenting self-efficacy. So depression and anxiety were both significantly negatively associated with parenting self-efficacy, with unstandardized coefficients of -0.45 and -0.74 respectively. Among the psychosocial factors, behavioral activation, mood management, and perceived social support were all significant positive predictors, and perceived stress was a significant negative predictor. Decentering and rumination was the only psychosocial factor that wasn't significantly associated with parenting self-efficacy, and these initial findings informed the further exploration of which psychosocial factors might explain the relationship between depression or anxiety and parenting self-efficacy. To examine whether psychosocial factors predicted parenting self-efficacy beyond depression and anxiety, I ran a series of multiple regression models. So here I'll just present the depression findings, but they were very similar for anxiety. There was a consistent pattern. So when psychosocial factors were added to models containing depression, depression was no longer a statistically significant predictor of parenting self-efficacy. So for example, when controlling for behavioral activation, the coefficient for depression decreased from -0.45 to -0.17 and was no longer statistically significant. And similar patterns were observed when controlling for mood management and perceived social support. This attenuation of the depression relationship is consistent with mediation, which suggests that these psychosocial factors might explain the relationship between depressive symptoms and parenting self-efficacy, and no significant moderation effects were found. The Akaike information criterion was then compared to identify the most parsimonious model, and the final models explained 38% and 39% of the variance in parenting self-efficacy for the depression and anxiety models, respectively. This figure displays the unstandardized regression coefficients with bootstrap 95% confidence intervals for both models. And blue points indicate statistically significant predictors at p is less than 0.05, while red points indicate non-significant predictors. Beginning with the depression model on the right, behavioral activation, mood management, and perceived social support were all significant positive predictors of parenting self-efficacy, as is indicated by those blue points and the confidence intervals. And perceived stress, which is shown in red, was marginally significant. Depression itself was no longer a significant predictor. And the anxiety model on the left had a really similar pattern. Anxiety wasn't a significant predictor when other psychosocial factors were included in the model, and behavioral activation, mood management, and perceived social support, as well as perceived stress, were all significant. The consistency of these findings across both models might suggest that psychosocial factors, particularly behavioral activation, mood management, and social support, are more proximal predictors of parenting self-efficacy than depressive or anxiety symptoms alone. So these findings have some important implications for understanding the relationship between postpartum depression or anxiety and parenting self-efficacy. Behavioral activation emerged as the most robust predictor of parenting self-efficacy in this study, and when behavioral activation was included in models with those mental health outcomes, the mental health outcomes were no longer statistically significant, while behavioral activation remained highly significant. This suggests that behavioral activation might be a critical mechanism through which postpartum depression or anxiety affect parenting self-efficacy, and this aligns with existing evidence that demonstrates the effectiveness of behavioral activation interventions for postpartum depression. Notably, behavioral activation interventions can be delivered virtually and/or by non-clinicians, which has important implications for accessibility of services, especially for underserved populations, including Latinas. Mood management and perceived social support also emerged as independent predictors of parenting self-efficacy, and these findings suggest that interventions addressing emotion regulation skills and facilitating social connections may directly benefit parenting outcomes for families that are experiencing perinatal mental health issues. Collectively, these results indicate that targeting specific psychosocial skills might be more effective for supporting parenting self-efficacy than interventions that broadly target depression or anxiety symptoms alone. There are several limitations I want to acknowledge. First, this was a cross-sectional secondary analysis of baseline data, so causal inference is not possible. These findings are preliminary and they definitely require further study. Second, the sample size of 88 participants limits statistical power to detect smaller effects or interactions. Third, the symptom severity in the sample was low, and while that aligns with the prevention-focused approach of the original study, that can limit generalizability of the findings to those with greater symptom severity. Fourth, parenting self-efficacy scores had a ceiling effect, with most participants scoring near the scale maximum. This might have reflected social desirability bias and cultural norms to indicate higher parenting self-efficacy than one may actually feel, potentially limiting validity of the analyses, and the restricted variance might also have attenuated associations or limited the ability to detect relationships with smaller effect sizes. And finally, the reliance on self-report measures captures perceived parenting ability rather than actual parenting behavior and may also be subject to social desirability bias. So to address those limitations and further explore these questions, it could be useful to conduct longitudinal studies with larger samples. It would also be useful to incorporate measures of economic hardship, which weren't included due to high levels of missing data, but these variables are highly relevant as they impact both mental health and parenting self-efficacy, and this population is at an increased risk for economic hardship. Additionally, to further contextualize the relationship between parenting self-efficacy and perinatal mental health, it would be valuable to also conduct qualitative research with mothers and families. And finally, it would be useful to explore the role of population-specific stressors like immigration-related adversity in parenting and perinatal mental health, both qualitatively and quantitatively. In conclusion, these findings suggest that psychosocial factors are stronger, more proximal predictors of parenting self-efficacy than depression or anxiety symptoms alone among Latina mothers at risk for postpartum depression. Specifically, behavioral activation, mood management, perceived social support, and perceived stress emerge as significant correlates of parenting self-efficacy and appear to mediate the relationship between perinatal mood symptoms and parenting outcomes. These findings have direct implications for intervention development. Clinicians and program developers working with this population should consider explicitly targeting these psychosocial factors as intervention components to strengthen parenting self-efficacy. These results also align with existing evidence that programs such as Mothers and Babies, which utilize cognitive behavioral therapy-based approaches and explicitly address behavioral activation, are well suited for this population. And these findings can also inform the development of culturally responsive, community-based perinatal interventions that address both maternal mental health and parenting outcomes for Latina mothers. Before I end, I wanted to say thank you again to my academic advisor, Dr. Karp, and also my reader, Dr. Platt, for all their support, and thank you all for listening.
Thank you. Wonderful job, Anusha. And I know you were rushing through that to keep us to time. So thank you so much, and we appreciate you finding some better internet so that we could actually hear you as you shared this very important work. And this was a really comprehensive analysis, and I'm just thrilled to see it all come together. Does anyone have a specific question for Anusha that they would like to ask either via the chat or by unmuting? Well, I'll ask you one question, Anusha. Were these findings what you anticipated that you would see in your data, or were you expecting that those psychosocial factors wouldn't operate in terms of your outcomes on this way?
I think it was what I was expecting. I've been able to go to the mothers and babies group that they have in person, and I know a lot of the moms say that they feel like the behavioral activation session specifically was really impactful for them. And it was also nice for them to feel like just because they might be having depressive symptoms, they are not necessarily going to be a bad parent and there's things that they can do. So I think that really aligned with what they've been saying, and I feel like it would be really exciting to get some like interview data directly to hear about these things from them.
Yeah, that's a great point. Very interesting presentation, and some pretty important implications of your work for the broader study team. I know that they're doing the intervention activities and other programmatic activities related to this population and this health outcome. So thank you so much for sharing. Thank you for pivoting there so that we could all hear you, and really excellent presentation. And if everybody could join me in giving Anusha a big round of applause, as well as a round of applause for our presenters today. Thank you all so much for joining. And I think this concludes our session for the day. So thank you so much, and congrats to everyone.